Sublaxated lens is a real challenge, and we need to correct it to have a long-term vision stability. Then injection of a dispersive OVD to form the anterior chamber and to stabilize the anterior vitreous face, followed by creation of the capsular axis. Bimanual capsular axis is needed in some situations to adjust the size, position and shape of the capsular axis. Capsular hooks will help to pull the bag and support it to facilitate completion of the capsular axis. Then hydrodissection to separate the soft lens material from the capsular bag. Then aspiration of this soft material using the coaxial IA, helped by the adjustment of the intraocular pressure by the active fluidics. The intraocular pressure here is 30 mm mercury, will help to stabilize the anterior chamber and to stabilize the vitreous. After removal of the lens matter, then why not to have a posterior capsular axis, as such cases will have very fast opacification of the posterior capsule. Puncturing the posterior capsule, injection of a cohesive OVD to separate the posterior capsule from the anterior vitreous face. Fashioning of the posterior capsular axis in my hands is easy and controlled as the capsule is elastic. Centralization of the capsular axis is mandatory. Posterior capsular axis should be aligned with the IOL optic. After that, placing the CTR is crucial in such situation to conform the shape of the bag. Usually the microforceps gives me much more control for placement of the posterior capsular axis. Then removal of the capsule support, and then enlarging the anterior capsular axis to be matching with the posterior capsular axis and have a clear visual X. After that, placing Ahmed segment to support the capsular bag and to anchor the bag into the wall of the globe. Marking 2 mm away from the limbus to pass the insulin needle, then passing the 6O prolene suture, pass through the hooklet of the Ahmed segment, then threading the 6O prolene suture into the insulin needle. After that, placing the Ahmed segment into its proper position and elevating the hooklet above the anterior capsule, followed by cauterization of the 6O prolene suture to have the flange. After that, injection of the 3-piece IOL into the anterior chamber first, and then placing the first prolene haptic into the bag using a blunt tip microforceps, then placing the second haptic into the bag. Now the IOL is completely inside the bag with the clear visual X, and after that pulling the edges of the pupil to adjust its shape, and finally securing the corneal wound with 10O nylon suture. At the end of the surgery, removal of the OVDs from the anterior chamber and the hydration of the wound. Now the eye is fully inflated, and removal of the trocar at the end of the surgery, massaging the conjunctiva, injection of a combination of steroid antibiotic into the subconjunctival space. Finally, active sentry, good anterior and posterior capsular access, CTR, Ahmed segment, 6O prolene suture, and 3-piece IOL is the key of success in sublaxated lens. Thank you for your attention.